I want to, and I want to make sure everybody knows what we are talking about here. So some of you may know Dr. Teran from his time at Mount Sinai. He is an emergency room physician or emergentologist and an investigator at the Weill Cornell School of Medicine. He completed a fellowship in emergency ultrasound at Mount Sinai Hospital and a master's in science and clinical epidemiology at UPenn. As a leading expert in emergency and critical care ultrasound, Dr. Teran's research focuses on the study of strategies to improve outcomes in cardiac arrest resuscitation, specifically incorporating TEE. He's the founder of Resuscitative TEE project and the PI of the multi-center TEE collaborative registry, which aims to accelerate the development of outcome-oriented research and knowledge translation on the use of TEE in emergency and critical care settings. There he serves as the co-chair of the Scientific Oversight Committee. As the course director for Resuscitative TEE workshop, he leads a group of multidisciplinary experts who have helped train over 1,000 physicians in US, Canada, Europe, and Australia. And that includes courses for the Society of Academic Emergency Medicine, the Emergency Medicine Residents Association, and the WINFocus, World Interactive Network, focused on critical ultrasound. So with great pleasure, I welcome Dr. Teran back to Mount Sinai to share his unique perspective on the use of TEE in emergency and critical care landscapes.
Thank you so much, Umesh. This is a true honor for me, and I'm very excited, but mostly honored and grateful for this invitation. This is a kind of a homecoming, I guess, a virtual homecoming, we will call it, to Mount Sinai, the place where I learn everything I know about emergency medicine, certainly, and many of the things that I've then taken to work in the other institutions where I've been lucky to work at. I have a number of friends there that I don't know if will be joining this lecture, but I wanted to also acknowledge and thank Evan for putting this together, for inviting me to NIHA and the rest of the critical care group at Mount Sinai. I have great memories from the days that I trained there. Mark Stone, I don't know if anybody knows him, but he's one of my mentors actually, who gave me the first exposure to transesophageal echo, specifically in the operating rooms. And I'm forever grateful to him and his team in cardiothoracic anesthesiology for welcoming me and for allowing me to learn with them and to be generous enough to share their expertise. And so what I want to do today is sort of pay back to some extent some of what I've learned over the last few years. I think that's a good way to put it. As you described, I am a researcher. I'm obviously junior faculty, still, building my career, but I've been very fortunate in the past few years to be able to get to work on this very specific area, you could call it niche, and that is the use of transesophageal echo, specifically in resuscitation. And I'll describe the more kind of with more in more precise terms, the scope of what we mean by resuscitative TEE in a minute. But in a nutshell, this has been the area of work that I've been concentrated, sort of, I've been dedicated to for the past 5 or 6 years. And that is the study of how we can improve outcomes, how we can improve the care of patients that are critically ill, whether it's in the emergency department, resuscitation setting, or in the ICU, whatever that type of ICU that is, or the operating room, or anywhere else. And so what I'm going to share with you is, of course, my perspective as an emergency physician. I do have experience from working in an ED-ICU at University of Pennsylvania, and I've had a great interest in critical care patients, but I'm not an intensivist like most of you. So what you'll find hopefully is that many of these concepts are applicable to the practice, to the ICU practice, and I'm going to try to concentrate in how which of those examples are relevant for your practice. As Umesh mentioned, also, I'm part of the Resuscitative TEE project. This is a multidisciplinary initiative that aims to advance and disseminate knowledge in the practice of TEE across the acute care settings. This is the emergency department at University of Pennsylvania, where I worked at till a few months ago, earlier this year. And this is the setup of one of our resuscitations. We were lucky there to have transesophageal echo implemented, incorporated as our standard for cardiac arrest resuscitations. And in those cases where we were lucky enough to get a notification with some time, we would be able to prepare the room for that patient about to come in. And what you see here is the head of the bed. There's a senior resident. That person is ready and prepared to intubate that patient if the patient didn't come intubated from the field. You see a CMAC there, a video laryngoscopy device. There's another physician at the feet of the bed there with an ultrasound machine ready for access to gain access on the patient as soon as that is needed. And the same physician at the head of the bed here is the person that after dealing with the A for airway and intubation, if needed, is going to be inserting the TEE probe that you actually see hanging from an IV pole right here. So this is an image that I like because it really depicts how we conceive the use of this modality in resuscitation specifically. TEE has become an additional monitor for us in resuscitation. And when I show you examples of how that exactly takes place, I do have a couple of disclosures of work that I've done with industry and on the educational realm of things. And so you should be aware of that. I'm also the director of the Resuscitative TEE workshop, a course that a few, I think, of the people attending the lecture today have taken. So take everything I say with a grain of salt from that perspective. I'm obviously passionate and to some extent degree of bias, healthy degree of bias, I want to say. If anybody's interested, this is a review that we put together last year with a number of experts from the US and Canada in this field, and it's a comprehensive review on the topic specifically of TEE in cardiac arrest resuscitation. If you're interested, I'm not going to cover everything, and I'm not going to make justice to all the work that has been done in this area. So if you're interested in some of the literature, and many of the citations are nicely organized in that review from Jack last year. Umesh also mentioned the work through the TEE Collaborative Registry. As a new modality or as a new application of this modality in critical care patients and emergency setting patients, we have started a registry, international at this point, registry, essentially bringing together all the centers that are using this modality to study outcomes, to study complications, to understand the impact that this modality can have in the care of critically ill patients. And this is an example of, this is a map from a publication that is pending publication right now of the current use of TEE in emergency departments. It's actually, at this point, slightly old data from almost 2 years ago. At this point, it's almost 50 or 55 programs across the country. But to give you a sense, this is still a minority of emergency departments across the country, but it's a rapidly growing number of departments. This is specifically emergency departments that have the capability of using TEE in emergency setting. So it is a reality, as I'd like to say. There's a quote from, I forget who said the quote, but the quote is, the future is here, it's just not evenly distributed yet. And I think that is a reality in the use of TEE in the emergency settings. With that, I want to, if anybody's interested in the work of that registry, specifically the application in the website listed there at the bottom of the slide, you can see the details of that collaboration. And if you're interested, and we would love to have any of the units at Mount Sinai participate from this registry, we're close to getting 200 patients in the first 3 months of of data that we collected, just to give you a sense of what is it that we're studying. These are the 5 indications that we're studying within that registry: out of hospital arrest, in hospital cardiac arrest, patients with acute decompensation in the setting of shock and indifferentiated shock. So patients that are fresh, that are hypertensive, and that we don't understand why they're in shock. Hemodynamic monitoring, so using TEE as a tool to assess continuously patients with as a hemodynamic monitor. And then procedural guidance. I'll describe. There's a number of procedures that we can do more effectively, more safely, potentially with a TEE. And we're studying those 5. Each of those indications are the applications for which we're collecting data across the over 40 centers that are part of the collaborative now. So in order to, I think, start discussing how TEE is useful, has impacted our practice, I think the best natural place to start is defining the scope and defining what is it that we're talking about. When we say resuscitative TEE, which is the term that we have coined or preferred within our group, is a term that it is synonymous and essentially describes exactly the same as other related terms that you see here. So rescue TEE is the term that you find in the literature of anesthesiology, specifically for the past 20 years. In any TEEs done in the sort of emergency setting within the operating room environment, those are referred as rescue TEEs and most the literature. Focus TEE or point of care TEE, those are all going to be terms that are defining the same or more or less the same thing. And the big distinction here is with comprehensive TEE. Many or some of you here might have a cardiology background perhaps and might have comprehensive echocardiography training, and you might perform comprehensive echo, including TEEs, as part of your practice. Well, that is what our cardiology colleagues and some cardiac anesthesiologists do in the operating room. This is not what we do here. We do what we mean about resuscitative TEE is not really a comprehensive study, of course, but rather just like we use emergency echo in any setting, whether it's TTE or surface ultrasound, we have one specific question at hand that we're trying to answer. And so it is goal-directed and it's question-driven and it's at the bedside. And we're using this modality to this more specific modality to answer that question, to obtain that data that is not otherwise obtainable. And so it is not exactly about the number of views, and many of the reports and studies within this field describe different protocols with 4 views, with 6 views, with 8 views. But what I want to communicate to you is that rather than a specific number of views, what really defines resuscitative or focused TEE in emergency or critical care is the scope of practice, the questions that we ask, and that is the main distinction. And so everything that I'll describe today here is within the realm of focus or resuscitative TEE, and that is what any emergency physician or intensive care physician or anesthesiologist with the proper training, as I'll show you, can do and should do. When we talk about this core views, the views that you will see in some of the cases that I'll describe to you, and this is in case that you might not be familiar with TEE at all, or might have not seen images, these are those 4 core views. So mid-esophageal 4-chamber, mid-esophageal long axis view on the top right, transgastric short axis, and then bicaval view. If you have experience with transthoracic, and I know that as an intensivist, most of you do have experience with transthoracic, you will recognize that these images are essentially mirror images. They are flipped images, especially the top 2 images, 4-chamber and a transthoracic partial long, respectively, and transgastric short axis would be exactly equivalent as a transthoracic short axis view. In the case of bicaval, it's a one view that there's no quite an equivalent in transthoracic. In that view, we're, as you see, they're cutting through the right atrium and through the SVC and IVC in the same place. And this is a very handy and useful view for the critical care setting that I'll show you examples for. But these are the core 4 views. When we train people on focus resuscitative TEE, these are some of those key views that we aim to teach people, and the studies that we and others have performed have shown that it is fairly feasible to teach and to have emergency and critical care physicians be competent at acquiring these 4 views and interpreting them. Some additional views include dedicated views of the left ventricle, additional views for the aortic valve, for instance, dedicated views of the ascending aorta. And depending on the question that we have at hand, again, which is the key of this of this modality, we're going to be using or deploying some of these additional views. For instance, if we're specifically worried about the right ventricle or some pathology on the right ventricle, there are dedicated views that we can quickly deploy and easily deploy to answer those questions. So right ventricle inflow outflow tract will be one of these quote unquote more alternative or additional views that we use on a case-by-case basis. Deep transgastric view, which you see here on the bottom right corner, is a view where we're advancing the probe all the way to the far portion of the stomach and then anti-flecting all the way to image the heart now through the apex, as opposed to through the base of the heart, as in the rest of metaesophageal images. So that's one of the views that we use commonly for hemodynamic monitoring, because we have really good angle of interrogation for Doppler through the left ventricular outflow tract, through the bicuspid, or through the mitral valve. And so these are, again, going to be additional views that we use. For instance, if we're interested in troubleshooting or assisting in the guiding placement of procedures. For instance, Impella catheters are becoming more and more ubiquitous. Intra-aortic balloon pumps, VA ECMO cannulations, as I'll show you in a few examples. Depending, again, on what is the need that you had, we might recruit some of these additional views, but again, still always within this focus perspective. So then the next question, after having defined the scope and kind of the nomenclature of what we are talking about here, would be to answer the question of why. Why do you need resuscitative TEE in your practice as an intensivist, as an emergency doctor? Well, I think you might agree with me, hopefully, that whether you're an emergency physician or an intensive care doctor or an anesthesiologist, that echocardiography is the standard of care in the assessment of patients that are in shock, in the ICU setting, or in anywhere. When you have a patient in shock in front of you, one of the things that needs to be done is that you have to look at the patient's heart. It is a fundamental piece of the assessment of any patient in shock. And so if we assume that to be true, and again, I believe that that is the case, we also know that sometimes, unfortunately, more often than we would like to accept, we can't meet that standard of care. We can't provide that information with transthoracic, whether it's mechanical ventilation, whether it's emphysema in the setting of COPD, whether it's just the body habits of our patients, or because the patient just had a sternotomy and there's just dressings in the chest. For a number of reasons, there are patients in whom, while we need that information, we need to look at their heart to answer those questions, we can't obtain that information with TTE. And so it is in those patients where TE is simply the tool that allows us to meet that standard of care. In essence, it is the tool, the right tool for the right job. And so the image that you see here is actually one of my colleagues at Penn doing a TE intra-arrest, doing the resuscitation of a patient with out-of-hospital arrest. You see two of our colleagues actually preparing for cannulation for ECMO, for VA ECMO, as part of the ECPR program, in one of the patients that met criteria for inclusion in that program. So then why, so I think that is a central argument. The argument is, well, there are patients in whom TTE is simply not able to provide us the information we need. And I believe that everybody, regardless of their situation, should be able to obtain that information. So in some cases, that information needs to be obtained with transesophageal echo. Another important argument, I think, for intensivists, for emergency docs, for anesthesiologists, is that TE really builds on existing motor skills, the core motor and cognitive skills that are part of our, I think that defines us as critical care emergency physicians. Hand-eye coordination, the kinesthetic abilities, that's the sensory perception of movement, are at the core of procedural training, both for intensivists and emergency physicians. That is what we do, and we need to be good at it. And we are good at it. And so whether it's ultrasound guidance of procedures, airway management maneuvers, video laryngoscopy, NPL, as the picture that shows here, one of our residents, we do have skills for those procedures. And it is the same type of, it is those same type of motor cognitive skills that we can recruit, that we can use to incorporate TEE in our practice without much difficulty. And the last important argument, I think, is that transesophageal echo, even though many might feel slightly intimidated by it, it is my hope with this lecture to sort of demythify and kind of, if you will, make it as simple as possible. And one of the things that the people tend to feel overwhelmed by is the number of views. As I showed you in that poster earlier, there are 28 views in transesophageal echo for a comprehensive examination. And so a lot of people feel sort of intimidated by that. And of course, you do need extensive training to be competent at obtaining all those views reliably. But the beauty of transesophageal echo is that once you understand the fundamentals, once you understand the perspectives of the views and the anatomy and know how the knobs work, just like with any other tool, then you can expand your practice. You can expand or elevate the complexity of your questions, the sophistication of your questions to whatever extent you want. And the good news, and this is a term that was sort of brought up to me by Rob Arnfield, an intensivist from Canada that actually, interestingly, spent time at Mount Sinai training as well in the same ultrasound program that I did with Brett Nelson and others. And Rob brought sort of presented this concept to me, which I think is really a neat one, and it's the idea of a scalable complexity. So if you learn the basics of TEE, you will be able to do exactly what you do with TT, which is answered at least questions regarding qualitative size and function, presence of effusion, cardiac filling status, cardiac arrest, identify whether there's cardiac activity or not. What is the heart doing? And within that, as I'll show you in a minute, in the possibility of improving CPR quality. And you need very little training to become competent at developing the views that you need to answer those questions in that part of the spectrum. With more training, with more experience, you can then become proficient use TEE to guide all sort of procedures, as I described earlier, to do hemodynamic monitoring if you have the knowledge of Doppler and understanding of some of those additional concepts, and all the way to the full scope of advanced critical care echocardiography, which now has been formally not just created not just a formal training and credentialing pathway has been created with a new critical care echocardiography certification, which I highly recommend for any intensivist in training to take. It is now a formal recognition of the full menu of applications of echo and critical care that includes TEE. And so the beauty of this is that the largest benefit is going to be in the early portion of that curve. And so with the fundamentals to be able to develop those initial views, we can answer 80 or 90% of the questions they're going to have in the context of critical care patients. Why is it also a modality that you might decide to pick up? Because in contrast to transthoracic, where if you remember from when you were learning transthoracic or when you were teaching transthoracic to your trainees, it is rather challenging to actually get good views in transthoracic. Develop the views is rather challenging. It takes some time to get good at that. In contrast to that, with transesophageal echo, acquiring images is actually fairly simple. Much more simple compared to TTE. And so it is easy to obtain those images and have the information available. And the challenge is, from my perspective, most of the time to actually interpret the images, understand the anatomy, remain oriented. So one of the key features of TEE, especially for the critical care environment, is that, and this is, again, a concept that I've borrow from other people smarter than myself, but one, and much of the work done in this field has been led by Paul Mayo and his group, Seth Koenig, Mangala at now Northwell in New York. And one of the concepts is the use of TEE as a continuous monitor, as a tool that can allow us not just take the snapshots of patients in one time, but as you see in this picture, a TEE probe is hanging from an IV pole. It is inside the patient, and we have the TEE machine next to a cardiac monitor, next to the ventilator. We have a 4-chamber view in view. This is the standard for myself in my group. Every time we resuscitate a patient from cardiac arrest, the next 20, 30 minutes, when the patients are very sort of fragile and prone to rearrest, we have that information, that image in real time in display, so that the nurses, the entire team can see that, and we can perform continuous reassessments. And you can say the same for patients that are in shock, that are doing that initial resuscitation in your unit, that are receiving fluids, where you're still trying to troubleshoot or establish the ideal combination, the real formula between fluids and pressors, for instance. Then you can use TEE to see in real time whether those interventions that you're doing are actually working. This paper from Jean-Louis Vincent, one of the intensivists in Europe, who's been describing the use of TEE in critical care for decades now, wrote this beautiful paper describing the sort of a concept paper describing how TEE is really an ideal hemodynamic monitor. And he describes here what represents an ideal hemodynamic monitor, which is what you see listed here. So I highly recommend to check the publication out if you're a trainee or if you're interested in hemodynamic monitoring in the ICU. Makes really smart comparisons with PA catheters, swans, and other devices, and makes you understand how TEE really shares some of many of these features that he describes as an ideal hemodynamic monitor. So enough of that. I think with that, we have enough of an introduction. I want to give you now some real examples of clinical practice, how TEE has impacted the care of our patients. If we boil down this to its core applications, we can summarize the use of transesophageal echo in these 2 applications. Shock is going to be essentially using TEE for the assessment of patients with either undifferentiated shock or early stages of their shock, to understand what components of shock, what the potential etiology is, perform continuous hemodynamic assessments of the LV, RV function. The ever important question of fluid responsiveness or preload tolerance, if you prefer, is something we can do very easily with TEE. And then, as I will describe, many of the procedures that we need to do in patients that are shocked as part of their support and part of the monitoring, such as intravenous pacing, such as, again, intra-aortic balloon pumps, Impalas, ECMO. Many of those things will be ideally placed and guided with transesophageal echo. And the other large sort of group of patients is going to be cardiac arrest, whether it's in hospital arrest or out of hospital arrest. Just like it occurs in the operative setting, we have an ideal opportunity to assess those patients in cardiac arrest with TEE. And we're going to answer the same, or ask the same questions that we ask with TTE, and that includes trying to identify a reversal pathology. Is there a large, massive PE that prompted this patient in my unit to arrest? And can look for signs to suggest that. Assessment of interventions. We throw everything at the wall and wait to see what sticks. That's kind of how we run many resuscitations. We have an opportunity with TEE to actually see in real time whether what we're doing with that patient is actually working, whether that's the pressors, the epinephrine, or for instance, treatment with thrombolytics. But really what makes transesophageal echo unique when it comes to cardiac arrest resuscitation is the potential to improve CPR quality. This is at the core of my work as a researcher, and is something that I'll obviously feel very strong about. It is a defining feature, I think, of this modality in cardiac arrest, the fact that we can look at the heart in real time throughout the entire resuscitation. And same as in the case of shock, in cardiac arrest, there are a number of procedures that we are performing more and more often now in patients in cardiac arrest that can benefit from guiding those placements, those procedures with TE. So guidance or assessment of patients in shock with TE. I want to give you a couple of examples. This is a patient over 600 pounds who was signed out in our EDACU with septic shock, a young male with no other medical history other than the overweight. And this patient was febrile, in profound shock clinically and by blood pressures. And the team had started all the standard measures of that you would imagine are needed in that case. So a patient was receiving antibiotics, was receiving fluids, had received antibiotics. And unfortunately, because of the penis of this patient, transthoracic, which is not able to provide any images. So until the point I got signed on this patient, we had not been able to get TT or any images of the heart, essentially. So as part of the assessment of the patient, and the patient was intubated, it's important to say, we did a transesophageal echo. The images actually from this patient are the two on the left. So I'm sorry, the two on the side. So image on the left, far left and the far right. And what you see here is essentially not the heart, not the ventricular function that you would expect in a case of pure septic or distributive shock, where you would expect to have the heart doing everything it can, especially in a young patient, to compensate for that shock state, where compensate for that peripheral vasodilation. So in this case, we immediately understood that there was also a cardiogenic component, that is this EF, whether it's 10%, whatever you want to call it. It is just not what we were expecting. Again, in a case of septic shock, we were expecting to see a hyperdynamic heart with good left ventricular function. And so that immediately impacted the management and the strategy of management of that patient. This is a lady that came in also with shock, profoundly hypertensive, that was intubated in the setting of airway protection. And this patient had a history of having had an ablation only a few days prior to this decompensation. And what we immediately obviously wanted to do was look at the heart. She had no transthoracic windows in this case, because she did have had multiple sternotomies and had just a lot of scars that just prevented from transthoracic images. In this case, the initial TE that we obtained showed this image of a large precordial effusion with physiology suggesting cardiac tamponade. So in this case, the etiology was obstructive shock. This was readily identified and interpreted with TE at the bedside. Some of these clips might not be playing here. Apologize, I don't know why that is the case. This was a patient that came in during the night with PA arrest, history of syncope in the field. Look at the heart, and the very first image of the intern gets is this image with this large mass on the right atrium. As you see here, this is empty RV. There's no blood, no flow to go into the left side of the heart. So this is essentially obstructive shock etiology or obstructive shock physiology leading to this arrest. So in this case, we were able to find what we thought was the culprit of the arrest. And there's no ACLS, there's no high quality of chest compressions or epinephrine or bicarb or calcium, whatever you want to give to your cardiac arrest that will help this patient. This patient needs to deviate from the standard ACLS pathway, and we need to treat that thrombus. In this case, that patient received thrombolytics. We at the bedside made a decision then to put the patient in ECMO and went for thrombectomy hours later. Another application that is distinctive of TE in TE is its ability to assess the aorta. As you might have experienced using transthoracic, it is rather frustrating to use transthoracic echo to look at the aorta, especially the descending thoracic aorta, because it's very far from the chest wall. And so in contrast to that, as you see in the simulator image on the left, a TE probe is situated right behind, obviously right behind the heart, and immediately next to the descending portion of the aorta, the thoracic aorta. And so that allows us to obtain really high quality images, as the one that you see here, may say that this is image needs a little bit of less decrease in the depth to maximize the size of that aorta.
I am, but I'm on another Zoom meeting right now. But I will turn it on when these ready, because they need to be in the camera.
Norma, could you mute yourself, please?
Sorry.
No problem. So an example of this is a patient that came in refractory VF arrest, was again also being prepared for VA ECMO in the setting of refractory VF arrest as one of the indications. And this was one of the images of the descending thoracic aorta, just because they're very pretty. This patient not only had a dissection of the descending thoracic aorta, but also of the ascending, and it was that ascending aorta dissection that was thought to be dissected in the coronary and had led to the VF arrest. So that patient also had what was thought to be the culprit or the etiology of the arrest identified during the resuscitation. Again, whether it's in the setting of blunt thoracic trauma, as we do in some cases, or in this case of a patient that was being prepared for ECMO. So the context of this here was actually, we were doing this descending thoracic aorta view to guide the arterial guide wire for the ECMO cannulation. And it was in that process where the flap was identified. So in that case, it was the indication was actually procedural guidance, but immediately the pathology became evident. And that is what you see there. Hemodynamic assessments as an intensivist, I'm sure you've been posed with a question of, should we give fluids or more fluids to this patient or not? And many of you have been taught or have used in your practice transthoracic echo, specifically the IVC assessment, as what many refer to as a kind of a magic bullet or panacea for the assessment for the question of fluid responsiveness. And unfortunately, the data with TTE and IVC assessment and mechanically ventilated or spontaneously breathing patients is clear at this point, and tells us that because of the number of factors that affect the IVC, specifically, it is a rather unreliable parameter. And in contrast with that, when we have an intubated patient, we have a fairly accurate assessment of the patient's fluid responsiveness or preload tolerance, again, if you will. There's studies from our colleagues in Europe, Antoine Villard-Veron and their group in the Paris ICU, who have demonstrated pretty sort of definitively at this point that the SVC diameter in mechanically ventilated patients can predict fluid responsiveness and is over IVC diameter, SVC diameter variation greater than 31 to 36% is what we generally use based on those studies. So how does that look in TEE in a real image? This is there we go. So that's a bicaval view, as you see in the simulator image on the left. We're basically imaging through the right atrium and through the SVC, which is on the right side of the image, of the TE image, and through the IVC on the left side of the image. We're doing that is simply then measuring diameter of inspiratory and expiratory diameter, and that is we're going to use to assess the likelihood of responsiveness. I mentioned also procedural guidance. This is a pretty broad area where, again, depending on the clinical environment where you work, depending on the type of patients that you see, that you treat, there might be more or less procedures that you can assist, that you can guide with a TEE. This is one of the examples that has been common in our practice, the use of VA ECMO for patients with refractory cardiac arrest, or you could say also for patients in cardiogenic shock. And that is specifically in the arrest setting. If you have any experience with VA ECMO, it is very challenging to identify to distinguish between artery and vein. So in this case, you see a cannulation being performed in the setting of VA ECMO. Both wires are going in there. Both vessels, the femoral vein and femoral artery, both look very similar. They're pulsatile. They're both pulsatile during the compression phase. And it is very, very difficult to actually distinguish between the two of them. And at Penn, when we started this program, we had the problem in a couple of consecutive patients, unfortunately, where the cardiothoracic surgeon that had cannulated was certain that had cannulated the artery, but unfortunately, after starting the pump, it was clear that the patient, the circuit was actually veno-venous as opposed to VA. And so in order to avoid that, we turned to TE to use TE as the method of confirmation, as our gold standard of confirmation that arterial guide wire was actually placed on the artery. And so in this case, you see in the top image on the right, the arterial guide wire depicted on the descending thoracic aorta long axis view. You see the tip right there. And that is how we definitively can say, yes, you are in the artery. You can advance your cannula over that wire. And similarly, on the venous side, the image you see on the bottom there, CPR is in progress, as you can appreciate there, based on the bouncing of that image. And you see the guide wire coming from the IVC on the left side of the image into the right atrium. And it is that same bicable view that allows us in the emergency or critical care setting, whatever it is that you're doing this, to actually then pretty accurately and elegantly, I would say, visualize how you advance that cannula, the actual cannula, over that wire and place it with as much precision as you need right at the RA-SVC junction. For those of you that might not be in doing or seeing VA ECMOs, you might be more familiar with VV ECMOs in the setting of your patients with ARDS or refractory hypoxemia. And it is in those patients, actually, especially with Avalon cannulas or cannulas where the placement of the cannula, not just the position, but the direction of the jet is actually relevant. So cases like that, you can very finely tune and very sort of precisely identify the position of the cannula, and put in Doppler, you can actually then orient that cannula to point towards your right atrium, especially if you're doing VV ECMO. So this is an example of, again, an application that we use fairly frequently as a standard of care for our ECPR program for cannulation of patients in VA ECMO. That was described by our colleagues in University of Utah, actually, as the first case series a few years ago, using TEE by emergency physicians to assist with the cannulation process. One of the cases that illustrated this application in procedural guidance, specifically in ECMO, actually was a heart transplant patient that I had not long ago. And this was a case that had been managed by another team initially. One of our heart transplant patients, this is at Penn, had come in. The heart transplant team was aware patient was altered, lethargic, needed to be intubated for airway protection immediately after arrival. And it was during the RSI that the patient actually went into VF. And immediately after, obviously, was shocked right away, right there. Right after coming out of VF, the patient was essentially in profound cardiogenic, or what we thought it was cardiogenic shock. Because this was a heart transplant, as you know from the heart center at Sinai, these are patients that are very closely followed, lots of resources go on them. So a lot of, with no hesitation in this case, the cardiothoracic team actually put this patient on ECMO, cannulated the patient, you could say crash ECMO right at the bedside in the emergency department. And the first thing that occurred there was that after completing the cannulation process, and at this point, I had not gotten to that room yet, and I was getting signed out in the other side of the department. And so the patient was put on ECMO very quickly. At that point, we didn't do TE to assist the cannulation, but the very first images that we obtained with TE include just assessment of the heart, the LV function, which was found to be, I don't know why this guy's not playing. Apologies for that. Rookie mistake here. I don't know what's going on with those clips. Hopefully this one will play. This one doesn't want to play either. And none of those is playing. The bottom line in this case is, unfortunately, I can show you the
Felipe,
clips.
it's okay.
Yeah.
You know, this happens often. Don't worry. You know,
Yeah.
sometimes
they're running, but they're just not playing. They just decided not to play right now. So what occurred in this case is that this patient's cannula actually, the team was concerned because the ECMO circuit was indicating 1 liter, essentially was just not enough flow. And what we saw in the bicameral view here was that there was no venous cannula. We couldn't see the venous cannula right here where we would expect to see it. So the next thing that we did was just advance a probe into the intrahepatic portion of the IVC, and we found the tip of the cannula. So in this case, it was actually fairly simple. What was occurring was that the cannula had not been advanced far enough, which was the reason why that cannula was creating a little bit of suction there, and the flows were insufficient. So after advancing that cannula into the RA and the RA SVC junction, the flows went from 1 to 4 or 5 liters, and the patient immediately improved hemodynamically from that perspective. And so this is an example of, again, at the bedside, how information yielded by TEE immediately help us troubleshoot, identify the problem, and assist in that procedure. And as I mentioned, oh, this is really sad because this images are very good. Have you actually, let me see the time. We're almost, so for this last few minutes, actually, what I'm gonna do is I'm gonna stop this presentation here for a second. Just bear with me. And I have a backup version of this lecture because I've learned that this sometimes happens. So I'm gonna pull that one out.
It's okay, Felipe. You know, we're going to have you back for sure.
Is that right?
Oh, yeah. I mean, this is the future, and you're not going anywhere, hopefully, other than up.
That's very kind of
Moving up.
you. Thank you.
So, you know, I suspect we're going to need quite a bit of time for Q&A. So
Yeah,
I invite
we can
you.
go in right now if you want to.
Yeah.
Actually, this is a good point. We have I loaded some additional clips here that we can go into if
Sure,
needed,
go
but
ahead.
if not, I think it's a good time. If there's questions, absolutely good time
Yeah.
to take on them.
I don't want you to feel pressured about, you know, showing a lot of stuff, but if you have something ready you want to go, is fine. Otherwise, I'm sure there's going to be a ton of people wanting to ask questions.
Absolutely. Please fire away.
Well, I certainly can start because it's an incredible advancement of technology in a very critical area. So I'd like a couple of things. One, you need a patient consent because this is out of ordinary or it's experimental. Do you need IRB? The other is how long, how many cases do you have to do to be proficient at doing this? Because I think putting a tube into a tube is relatively, quote, simple, but what you're looking at and measuring is fairly complex, especially in a dynamically, rapidly changing situation. And you showed some very dramatic cases, but I have no idea whether the procedure offered a diagnosis that was clear cut, but did it make a change in the outcome? Did it make a difference in the patient's life? And what was the salvage rate, quality of life issue, not just alive, but able to live a life? So I know that's a lot of questions at one time, but these are issues that come to mind when you're doing something new and different in a very, I call intensive, stress-producing anxiety state of a patient.
I suspect, Felipe, that this is going to take up the rest of the hour, the answer.
No, that's great. Yeah, so there's a lot of questions and we could discuss for a full hour. I'd appreciate that. Dr. Brown, so the first question is regarding consent. So we don't, this is just like any other critical care procedure. This is not experimental at this point. First of all, TEE has been used in anesthesia for over 30 years, and it's standard of care in many applications. Taking TEE to outside the operating room has also been a practice in many places for many years at this point, and is actually for specific indications a standard of care, and specifically in emergency medicine. It has been endorsed by the American Society of Emergency Physicians, the American College of Emergency Physicians, as the modality of choice. So at this point, we have sort of guideline level of recommendation specifically for cardiac arrest in the emergency medicine setting. In the critical care world, TEE is formally part of the scope of advanced critical care echocardiography practice. So myself, many in the among the attendees I know have taken the critical care echo boards recently in the past couple of years, and that test and that board certification process includes TEE as part of that scope. So TEE is formally within the scope of practice of advanced critical care echo. And some of the examples that I show here are applications of within that scope. And so in terms of consent, of course, we do need consent in certain research settings and certain studies, but particularly for the cardiac arrest cases, this is done as a standard of care in the centers where we have incorporated TEE as a part of our standard practice. In those cases, that is not, it is rather impossible to consent patients, so we have to use another set of mechanisms. But for the ICU, all the ICUs around the country that are using TEE as part of their focus TEE scope, part of the critical care echo scope, they are in some cases, depending on the indication, consenting patients and their families if there's such opportunity. For instance, if we're going to use TEE for guidance of intravenous pacemaker, just like you're going to consent for the pacemaker, or if you're going to use it to guide a cannulation for ECMO, same thing. But if it's an emergent situation, if it's an acute hemodynamic decompensation in one of the patients in the unit, and the TEE is available in that situation, just like we would not get consent for an emergent thoracotomy or for an emergent pericardiocentesis, in those cases, I think it makes sense to do this procedure. And we have a question actually from, so I think those are the two parts of the question that I can remember. I guess the last part that you did mention regarding outcomes. Yeah, so that's a $1 million question. Of course, we're interested in not just impacting decision-making, but also improving outcomes. There are studies showing improvement of outcomes when transesophageal echo is using the perioperative setting. Outside the operative setting for any of this critical care or emergency applications, it hasn't, there's no such studies. And unfortunately, there's actually no such studies for TTE either. If you explore the critical care TTE literature, you can find studies that demonstrate, improved survival or improved outcomes pretty much on any application. But just like we don't do randomized control trials to answer the question of whether, jumping off a plane with a parachute or not is what we should do, I think in this case with TEE, while we are conducting studies right now, and the registry is one of those efforts to accumulate data to answer more definitively the question of safety and characterize the safety profile, it is as well the type of data, multi-center perspective data, that will help us look at outcome-driven questions as well. But as of right now, there's no outcome data on outcomes on any of these applications other than short-term outcomes.
How about the cost, added cost?
Yeah, so cost of procedure for TEE, just like with any other point of care ultrasound modality, you need a machine. So if you don't have one, then you have to get one. But if the same critical ultrasound machines that you use in your units for TTE or for surface ultrasound, it is the same machine that you're going to use with a TTE, with a TEE probe. So many of the makers of point of care ultrasound systems at this point, or all of them, have TEE probes available essentially.
Also, the procedural costs are minimal, Dr. Brown. When you're spending $1 million on ECMO, this is...
Yeah, of course.
I'd like to give others a chance to ask questions as well. Thank you. So anyone else here would like to ask a question?
I have a question, Dr. Gidwani. How are you?
Go ahead.
How are you?
Great talk, Felipe. Yeah, I'm doing TEEs for the last 25 years. But some questions I have: do you try transthoracic first, and then if the transthoracic imaging is not good, then you go to TEE, or you go straight to TEE?
Yeah, that's a great question. So yes, so the answer is, if the situation permits, we do TTE. I think especially if it's a patient in shock, as you probably know, in most patients or in many, we can obtain the information we need with transthoracic, and especially if the patient is not intubated, yes, we do TTE and we obtain the data with that. If the clinical scenario is a cardiac arrest, I don't bother to do a transthoracic echo, and that's because I have enough experience with TE, seeing that again there is information that I can't quite obtain with transthoracic, and so it will depend on the clinical context.
And
But
the other question I have is, I mean, do you have a special protocol? Because, I mean, you know, or you know, a special protocol. I know you are experienced, but I know your residents and all this stuff, most likely they're not as experienced. And as we know, you know, unless you have a specific protocol, you may miss things, and of course, you don't want to do like a fishing expedition to go in and look, you know, you don't know what you are looking for. So do you have a specific protocol that you follow?
for sure, yeah, that's a great question. And we have at my institution or my institutions in the past, we've had protocols. If you, the same 4 core views that I showed earlier are the views that we use most of the time. When I was at Penn, we had a protocol with 6 views, including 2 of the aortic views in addition to those 4. And we had established a sequence starting with 4 chamber and then proceeding with the other views in the way that makes sense. Now, it also makes sense. I think the question really needs to be answered in the context, in the clinical context. So depending on really what the application is, which order, which sequence might make the more sense. If you're guiding a procedure, I'm going to go straight to the views that are going to help me to guide that procedure. In the setting of cardiac arrest, we have sort of established sequence that starts with 4 chamber, and then we go to assess the area of maximal compression. There are some attempts, I know in the anesthesia literature, rescue TEE protocols described. There are similar kind of descriptions in emergency medicine now, and we have, again, our own. But I think in contrast to comprehensive, where there are, again, very strict recommendations of what all the views that you need to obtain, in this case, it really needs to be driven by the clinical question at hand.
Yeah, and
Felipe, thank you. So Felipe, you really need to come up with a cute acronym such as FAST or slow or something like that, you know. But anyway, you know, Dr. Larakis is our specialist structural interventional ultrasonographer who does TEE for all our valve surgeries and so on.
That is amazing.
So, one more question we can squeeze in there. And thank you so much for such a broad, comprehensive look. So much advancement in such a short period of time. You're coming back to see us, Felipe. Any other questions?
If it's nobody, Dr. Gidwani, I have a practical question. During CPR, when you have the probe down, if you have to defibrillate the patient.
Yeah, that's a great question. So
what do you do? What do you do with the probe?
So the short answer is we leave it in place. And I can tell you, just based on my experience of doing, I don't know, hundreds of these, there's no problem. Nothing happens. Nobody gets electrocuted and the probe is fine. Also, if you look at what EP does, and like if the use of TEE for procedure guidance, especially in the EP setting, there's years of experience defibrillating patients with the probes in place, and again, that has no reported sort of complications from that. So that is our practice. We leave it in place. Yeah.
Yeah. I mean, I know it's not my literature on that. I mean, it's, as you know, some literature that you can cause problems on both the patient and the TEE probe, but I just want to get your your experience. But
yeah, it hasn't been our experience. Certainly, in the cardiac arrest cases, we do it. We don't take it out. We leave it in place. The probe is sealed electrically, so there shouldn't be passage of current through it. This is what you do a leak test every time that you have to send it for cleaning. But that's a question that comes up all the time.
Stam.
Thank you very much. Thank you.
I think we're going to have to wrap it up here. We have our next meeting coming up. But Stam, I will share Felipe's contact info and the two of you should talk because we really need to make this happen over here as well
Yeah.
as our ECMO cases skyrocket.
I'll be
Thank you
happy.
all
For
so
sure.
much.